Hello, everyone. We're going to be doing Chapter 11, the endocrine system. Um, Doing this because I'll be absent for this lecture. I've added some slides. I've tried to make it a little bit easier and try to correlate it to some things you may already know and some things you can use in clinical practice. So let's begin. There's about 80 some slides, and I don't think it'll be too bad. So the endocrine system. The endocrine system works with the nervous system together to maintain that homeostasis. So we talked about in earlier lectures, excuse me, or the balance within the body. Excuse me. The endocrine system is made up of the cells, tissues, and organs that secrete hormones into the body fluids. So remember, the endocrine system is going to work with the nervous system. The endocrine system is going to secrete hormones into the body fluids. The hormones diffuse into the bloodstream to act on target cells that is, some distance away from them. So the hormones, endocrine system secreting hormones going to target cells. The body has two kinds of glands. You're going to have exocrine. Those are the type that secrete products into ducts. And you're going to have the endocrine, and they secrete products into body fluids to affect target cells. Other types of cell secretions are pancreasins, they affect neighboring cells, and autocrines, they affect themselves. And I would remember that autocrines, auto itself, that's how I would remember that. Paracrines affect neighboring cells, autocrines affect themselves. So there are similarities and differences in how the nervous and endocrine systems work and communicate with each other. The endocrine system's function is to communicate with cells using chemicals called hormones. Endocrine glands and their hormones regulate a number of metabolic processes within cells and the whole body. And their actions are precise and they only affect specific target cells. So, just to reiterate, the endocrine system is going to excrete hormones. It's going to regulate metabolic processes, affects the whole body. Their actions are precise. Picture from your book. And it kind of shows the differences in the nervous system and the endocrine system. Again, the nervous system, cells, nervous system is going to affect neurons. The endocrine system is going to affect the epithelial and other tissues. Chemical signals, neurotransmitters for the nerves, it secretes neurotransmitters, and endocrine system is going to secrete hormones. The nervous system speed of onset is seconds, where the endocrine system can be seconds, depending on what hormone is being secreted, or it could go for hours. And the duration of action, very brief with the nervous system. It's usually, it acts and it's over. And with the endocrine system, it could be similar to the nervous system. It could be a brief hormone release, or it could last for days if needed. This is just a comparison between the nervous system and the endocrine system, where like I said, the nervous system is going to be neurotransmitters, nerve impulses, where the hormone system is going to be, hormones are going to be secreted from the endocrine system, and they're going to go after targeted cells. So endocrine, it's going to be hormones, again, target cells, and back to what the nervous system we just covered is going to be neurotransmitters and impulses. The endocrine glands include, and we're going to show you some pictures. I'm going to do this. I kind of added a few slides to try to remind us of where these are, because we just talked about the brain and the spinal cord. So hopefully you'll be a little bit familiar with some of these positions. The pituitary gland, the thyroid gland, parathyroid glands, adrenal glands, pancreas, pineal gland, reproductive glands, what's going to be ovaries and testes, the thymus, and other hormone-secreting tissues. Remember, the pituitary is going to be up in the skull, thyroid in the neck, and we'll move on down to the picture. As you can see, the hypothalamus we just talked about in a lecture, located up near the middle brain, a pituitary gland, which we talked about earlier, and a pineal gland, which I said in an earlier lecture we would further discuss, and we will in this lecture. You can see the parathyroid and thyroid gland in the neck area, thymus around middle chest, Adrenal glands are going to rest upon the kidneys. The pancreas is also a gland that secretes hormones. Then, of course, you have the reproductive, which would be testes or ovaries down lower. So hormones are steroids, amines, peptides, proteins, or glycoproteins. They can influence target cells even if they are present only in just a minute concentration. Just a very small amount of hormone can influence a cell. And here's just a table. It's found in your book. I'm not going to go through the whole table, but peptides are basically formed from amino acids. To pick out, when we're going to be talking about antidiuretic hormone, as you can see, which is a peptide and amino acid. That's going to be a hormone that's going to affect urine output. Your amines, what it says, comes from amino acids. And there's going to be such chemicals as norepinephrine and epinephrine. Those become prevalent with flight or fight mechanism and regulation of blood pressure. We give, for example, epinephrine injection for cardiac arrest. And we'll talk a little bit about cortisol, which is a steroid formed from overall cholesterol. So let's talk about your steroid hormones. Your steroid hormones are synthesized or come from cholesterol. They're fat or lipid soluble and can pass through membrane cells. They're carried in the bloodstream weakly bound to plasma proteins. So they're kind of carried along, but very weakly. It's a weak bond to these plasma proteins, which means they can be released pretty easily if they need to be. The receptors for steroid hormones are located in the target cell's nucleus. So it's going to be in the cell nucleus is where we're going to find the target cell that these steroids are going to go after. The hormone receptor complex binds with the DNA and activates specific genes that, in turn, direct the synthesis of specific proteins. And this is just an overview of how a steroid would be carried and released into the blood system. Overall, this is a cell nucleus, and this would be just a general cell. That's what they're depicting here. Then we have non-steroid hormones. So non-steroid hormones combine with receptors and target cell membranes. The receptors have a binding site and an activity site. So non-steroid hormones will differ because they have a binding site and an activity site. The hormone receptor complex is referred to as the first messenger, will trigger a cascade or start an event of biological activity through the cell membrane to the inside called the signal transduction. So it's almost like a ripple effect, if you can think of this. Non-steroidal hormones, going to repeat this, will trigger a messenger within the nucleus that will trigger a cascade of biological activity through the cell membrane to the inside. So it's going to go from the outside of the cell, and it's going to be carried to the inside. The hormone receptor complex generally activates a G protein, which then activates the enzyme adenylate cyclase that is bound to the inner cell membrane. The enzyme removes 2-phosphates from ATP. Now, let's just remember ATP is what is needed to produce energy. Let's go back to those basics. ATP is needed to produce cellular respiration and energy from a cell. If you don't have any ATP, you're going to die because your cells can't produce any energy and can't do respiration within the cell. So these enzymes remove 2-phosphates from ATP to produce cyclic AMP, which is going to become the second messenger of this hormone, which in turn activates protein enzymes that activate proteins. These activated proteins induce changes in the cell. Not all non-steroid hormones use cyclic AMP. Others use DAG or dicyclorol or inositol triphosphate, but many use DAG. Postganglions are locally produced lipids. Lipids are fats, to keep it simple, that usually affect the organ in which they are produced. So the Prostaglandins are just locally produced fats that are going to affect the organ right from where they come from. Whatever organ produces them, it's the organ they're going to affect. They produce a variety of effects, and I've kind of expanded this a little bit for you to help make it a little bit simpler. They produce many effects. Some are going to be relaxing smooth muscles. In other words, dilate, and that's going to affect blood pressure. Others contract smooth muscle. That would affect blood pressure also. Some will stimulate secretion of other hormones or chemicals. Some influence blood pressure, which goes into the muscle relaxing. Others affect reproductive physiology. And they are also, and I found this, I tried to get a couple different sites. Remember that these prostaglandins are powerful or could be powerful vasodilators, and they also inhibit platelet formations. As I found even further, which I'll go to the next slide, they can cause constriction or dilation in vascular smooth muscles. So these can affect your blood pressure. These hormones can cause platelets to either cluster or uncluster, which basically affects clotting time, because platelets is what helps clot your blood. So these hormones will affect clotting time, either make it longer or shorter. These hormones can induce labor. These hormones can decrease intraocular pressure, which is the pressure within the eyeball. They regulate inflammation throughout the whole body. They also regulate calcium movement, which will come into play also with blood pressure and with bone formation or deterioration. So hormone levels are precisely regulated. Hormones should be a very narrow range for hormones. The control mechanisms for these hormones are going to be the release of tropic hormones from the hypothalamus. The hypothalamus controls secretions of the anterior pituitary. Now remember, hypothalamus and pituitary are located just in middle brain, as we talked about before. The nervous system influences certain endocrine glands directly. So these hormones are going to be released from the hypothalamus and the anterior pituitary. The nervous system is going to influence the excretion of these hormones, of these glands to excrete the hormones. And then other glands are going to respond directly to the changes in the internal fluid composition. So going back, I've got a slide that follows that kind of reminds you where these are located. So again, precisely regulated. They can be controlled by the hypothalamus and the pituitary. The nervous system will influence these glands to secrete these hormones. These glands will also respond to changes in your fluids composition through your whole body. Just trying to keep it simple. Again, a picture of where these glands are located, just to keep you in reminder. Again, hypothalamus, pituitary, thyroid, thymus. So this is just a breakdown that's in your book. The hypothalamus, which we just a reminder of where these things are located. Hypothalamus will have the anterior pituitary gland excrete peripheral endocrine to affect the peripheral endocrine gland, which will affect target cells, which will cause an action. The nervous system will affect the endocrine gland that will affect target cells, which produce an action. And then also changing levels of substances in your plasma or blood will affect the endocrine gland that will affect target cells and action. So all this is doing is saying these hormones can be directly affected or regulated by the hypothalamus or the nervous system, or simply by changing fluid status in your blood. We have such things called negative feedback systems, and commonly a negative feedback mechanism controls hormonal releases. In a negative feedback system, a gland is sensitive to the concentration of the substance it regulates or which regulates it. So think about it as it's just a monitoring system that is looking for a particular substance in the blood, and it's going to regulate that. Think of it, and this is very loosely like a thermostat in your house. It's sensing the temperature, and it's going to either turn the air conditioning on or it's going to turn the heater on. That is a negative feedback system or example of it that you probably already are familiar with. When the concentration of the regulated substance reaches a certain level, and that's either going to be a high level or low level, it will inhibit the gland from secreting more of the hormone until the concentration returns to normal, which is going to be like the homeostasis for that. Again, it's just like a thermostat, a negative feedback system, looking for a concentration of whatever substance it's going to regulate, and then it's going to keep that substance between boundaries of high or low by either secreting more or secreting less. And this is just a picture of, the hormone secretion over time and how, as you can see here, it's keeping it. The negative feedback system is regulating the hormone to a high, to a low, to a high, to a low, but it's basically keeping it within range, is what we're showing here. Let's go to the pituitary. The pituitary is attached to the base of the brain by the stalk called the infundibulum that connects the pituitary gland to the hypothalamus. Like I said, we looked at this earlier when we did the lecture on the brain. You have an anterior pituitary. The anterior lobe consists mostly of glandular epithelial tissue arranged around blood vessels and enclosed in a capsule of collagenous connective tissue. Sorry for my mispronunciation. I get tongue-tied. The posterior pituitary, or the posterior lobe, consists of nerve fibers and neurological cells that support nerve fibers arising from the hypothalamus. So again, pituitary. You have an anterior and posterior, front and back. The front is going to be glandular, and it's going to be basically surrounded by connective tissue. The backside is going to be more nerve fibers and neurological cells. So you have anterior, front, and back pituitary. One is mainly made up of tissue and blood vessels. The backside is going to be made up of nerve fibers. Let's keep that simple. And there's a picture. As you can see, the pituitary gland is right there, and you can kind of get a reference to where it's located in the base or the top of the stalk as we go into the brain cavity here. The hypothalamus controls the activity of the pituitary gland. So pituitary gland, remember, has a front and a back. Hypothalamus is going to be the person or the control of that. Releasing and inhibiting hormones from the hypothalamus control the secretions of the anterior pituitary. So the hypothalamus controls the activity of the pituitary gland. It's going to release or inhibit hormones from the hypothalamus, control the secretions of the anterior pituitary. These hormones are carried in the bloodstream directly to the anterior pituitary by hydrocephalus portal veins. These veins connect the hypothalamus with the anterior pituitary. Remember, the anterior pituitary, the front part, is basically made up of tissue and circulatory system, veins and arteries. And so the hormone from the hypothalamus is going to come down through these portal veins. Let's keep it simple. That's what's going to affect the pituitary gland. Specific cells are then stimulated to release or stop releasing their hormone. The hypothalamic control of the pituitary gland, the posterior pituitary stores hormones. So now we're looking to the backside of the pituitary. It stores hormones made by the hypothalamus and then releases them into the bloodstream in response to the nerve impulses from the hypothalamus. So let's just think. We have the hypothalamus sitting on top of the pituitary, if you can visualize that. You've got these veins that directly connect the hypothalamus to the front part of the pituitary that supply hormone. So hypothalamus supplies hormone to the anterior pituitary. The back side of the pituitary is going to store up the hormones, and those hormones will be released from the back of the pituitary, the post pituitary that we talked about. Those are released also by nervous impulses from the hypothalamus. So the pituitary front part's going to receive the hormones through blood vessels. The back part's going to transmit out the hormones as needed by the nervous system. I hope that makes a little sense. And basically, here's a picture of the anterior, which is more blood vessel, and the posterior. Again, these are the portal veins that come down from the hypothalamus, which is going to give circulation to the anterior pituitary with hormone. There's going to be stored back here. I don't know. I think of a chipmunk storing stuff, storing to be released when needed by the control of the hypothalamus, and then it'll be controlled by the nervous system. Growth hormone, or GH, stimulates body cells to grow and reproduce. And this is out of the anterior pituitary hormones. It also speeds the rate at which cells use carbohydrates and fats. So growth hormone comes from the pituitary gland. This is a lot of times when a child goes through puberty, these growth hormones, puberty changes and all that, come from the growth hormone, which is produced by the pituitary glands. The growth hormone releasing hormone GHRH from the hypothalamus increases the amount of growth hormone released. Growth hormone release inhibiting hormone GHIH inhibits the release. So basically you have GH, which is going to affect the body growth and reproducing of cells, and then the GHIH is going to basically counteract if you have an overproduction of growth hormone, and that will create homeostasis. Now, the nutritional status affects the release of the growth hormone. More is released when nutrients are insufficient. So imbalances of the growth hormone, you can have pituitary dwarfism, deficiency during growing years, which is going to be, again, puberty. So if you don't have enough growth hormone, and this is regulated by the brain, and a lot of this is genetic, but it can produce dwarfism, which would be a small person. Giantism would be an oversecretion of the growth hormone. If anybody remembers wrestling, Andre the Giant, you could Google that if that's beyond your time. But anyway, that would be giantism. And then acromegaly is an oversecretion of the growth hormone that occurs after puberty and goes on into adulthood. See, as you remember, puberty only lasts a few years. Any of those have teenagers are thankful for that. And then the growth hormone will stop coming from the pituitary gland. However, if you become an adult and it's still producing growth hormone, you can have acromegaly. And I actually have a picture of this, so it means something to you right here. I got this from Wikipedia. Sometimes the onset can be middle age, where this growth hormone starts to produce again. These people may have hypertension, which is high blood pressure. They can have sleep apnea. There's many, many things, but I listed a few. They can have enlargement of the hands, the feet, forehead, the jaw, and get an even deeper voice. It's all an overproduction of growth hormone that should have stopped with puberty. Then again, on the pituitary, on the anterior side, you have prolactin, or PRL. Now, this prolactin promotes skin production following the birth of an infant, and that is only stimulated after the changes of a body after you give birth. Prolactin, as many women would say, my milk is coming in. That is as a result of the production of prolactin. And however you can remember that. No normal physiological role in males is known, which I don't think anybody would argue that. Then you have the thyroid stimulating hormone, or TSH, and that controls the secretion of hormones from the thyroid gland. Remember, the thyroid's in the neck, okay? Thyrotropin releasing hormone, or TRH, from the hypothalamus regulates the release of TSH. The hypothalamus really is the brain, which is located at the base of the brain, that part of the brain that really does kind of regulate how much of all the other hormone systems produce. So we already know that the hypothalamus affects the pituitary, anterior and posterior. It also affects the thyroid gland in the neck. Now, again, TSH and TRH from the thyroid. As blood concentrations of thyroid hormones increase, secretions of TRH and TSH decrease. So in other words, you need these hormones in your blood. Your body regulates them, monitors them, and if the TRH or TSH in your blood system is high or low, then the thyroid is supposed to come into play and send a signal up to the brain to say, look, I don't need any more, or I need more. Now, we'll talk a little bit about hypothyroidism and hyper, because a lot of people have this issue to where it's not regulating the TRH or the TSH effectively, and that can lead to some complications. And this is just an overall picture. Remember that hypothalamus is really the brain center of these hormones, of the hormone centers. As you can see there, how it affects the anterior pituitary. Remember, the anterior is the blood supply to the pituitary. The back end of the pituitary that you can see over here is basically the storage of the hormones. And basically how that affects by regulating, by looking at the TSH and TRH that's in the bloodstream, of how much is produced from the thyroid. Because remember, THS stimulates the secretion of certain thyroid hormones. So basically, it's like, again, kind of regulating, if you think about a thermostat, the bloodstream, it's regulating those two hormones in the bloodstream, and the thyroid will respond appropriately if it works correctly. Adrenocorticotropic hormone, or ACTH, controls secretions of hormones from the adrenal cortex. It is regulated by corticotropin releasing hormone from the hypothalamus, and stress can also increase its release. This is from the anterior pituitary. The anterior pituitary also secretes gonadotropins, and the way I remember that is think the word gonad. This is basically going to be your follicle stimulating hormone, or FSH, in females, luteinizing hormone, and that'll be in females, and it also affects the male testes and female ovary gonads. In males, LH is also known as interstitial cell stimulating hormone, or ICSH. So the pituitary gland is going to be what regulates FSH, LH in females, and ICSH in the male reproductive organs. So posterior pituitary, the back of the pituitary, neurons in the hypothalamus produce antidiuretic hormone, we call that ADH, and oxytocin, or OT, and they're stored in the posterior pituitary. Impulses from the hypothalamus will release the hormones. Antidiuretic hormone is going to be a hormone that, if you have an abundance of that, it's going to affect the kidneys and you will not pee as much. It is what it says, anti-diuretic, diuretic meaning pee or diurese. Oxytocin is going to be released in pregnancy. Your ADH, or antidiuretic hormone, produces its effect by causing the kidneys to conserve water. So it goes back to what I just said. The hypothalamus regulates the secretion of ADH based on the amount of water in the body fluids. Osmoreceptors sense changes in osmotic pressure in body fluids, which is basically going to be blood pressure, to keep that simple. And diabetes insipidus is basically an insufficient ADH production. So ADH is going to regulate that hormone is the thermostat per se that regulates whether you pee or you don't pee, depending on what your blood pressure is and what the amount of water is in your body. Oxytocin plays a role in childbirth by contracting the muscles of the uterine wall and in the milk letdown by forcing milk into ducts from the milk glands. Stretching of the uterus in the latter stages of pregnancy stimulates the release of oxytocin. Sucking of an infant on the breast stimulates release of oxytocin after childbirth, and release is controlled through positive feedback. And if you've had children, sometimes they induce labor by giving you oxytocin because it'll actually cause the uterus to start contracting. After birth, oxytocin has the uterus contract to try to stop bleeding. You would hope that would happen so you don't have a large amount of blood after birth of the child. And it's interesting that, as soon as the child is born, we usually put it up to the mother's breast. And again, just the infant sucking on the breast will help to release the oxytocin. So it's kind of like that built-in mechanism to help you stop bleeding after birth if everything is working right. And this is just a breakdown of, what the hormone is and the action and what controls it. And I'm sure this is directly out of your book. The thyroid. Now, the thyroid is located right in the neck below the larynx and consists of two broad lobes connecting by an isthmus. The structure of the gland, the thyroid, consists of a part that secretes, called follicles, filled with hormone-storing colloid. And this is just a breakdown. Again, this is in your neck, your thyroid gland. And you can see it in relation to the larynx. And then this is basically a cross section where you have colloid toward the middle, follicle cells surrounding that, and extra follicular cells surrounding those. So the thyroid, the hormones of the thyroid, the follicular cells produce two iodine-containing hormones, thyroxine, or T4, tetrahydrothyronine, and T3, tridothyronine, the more potent form of thyroxine, that together regulate energy metabolism. Now, this is going to come into play of people sometimes that gain weight, that don't gain weight, that can eat and never get fat, or some people never eat and they stay fat. It's all regulated by the thyroid hormones and the thyroid gland. These two hormones increase the rate at which cells release energy from carbohydrates, enhance the protein synthesis, and stimulate the breakdown of and mobilization of lipids or fats. Fats are basically lipids. These hormones are essential for normal growth and development of the nervous system maturation. So the thyroid hormones are the major factor in determining the basal metabolic rate, or BMR, often referred to. The hypothalamus and pituitary gland control the thyroid hormones. So again, hypothalamus, pituitary are going to be the master glands that they're going to control the thyroid glands. Iodine is needed for follicular cells to make thyroid hormones. And both hormones are transported in the blood by plasma proteins. Extrafollicular cells of the thyroid secrete calcitonin, which lowers blood levels of calcium and phosphate ions when they are too high. So calcitonin, calcium, think of that, however you want to remember that, is going to lower levels of calcium and phosphate ions when they are too high in the bloodstream. It's going to be regulated by the thyroid. Calcitonin increases the rate at which calcium is stored in bones by inhibiting osteoclast. And I wanted to remind you, I added this in here. Remember, osteoclast, going back to bone formation, which we lectured on earlier, break down bone, and osteoblast create bone. So calcitonin increases the rate at which calcium is stored in bones by inhibiting the osteoclast or the breakdown of bone and decreasing the excretion into the urine. Calcitonin secretion is regulated by negative feedback involving blood concentrations of calcium. So again, it's just regulating your blood for calcium. Do I need more? Do I need less? And it keeps it within those narrow boundaries. If you go into the lab, an MLT, and even respiratory, any of us, you will find that everything we look at in the blood has a high and a low range. And like I said, this is keeping it within range of everything is working correctly within the body. Thyroid disorders, hypothyroidism is going to be considered underactivity. Hypo, meaning low, of the thyroid gland. Hyperthyroidism, again, would be overactivity of the thyroid. Which, again, if you go back to, if the thyroid's not working, it could cause problems with calcium in the blood. It's going backwards a little bit. It's going to affect your basilar metabolic rate. So weight loss or gain, calcium deficiencies or overcalcium, anything like this can all go back to disorders of the thyroid, which is in the neck. And that's just to break down the hormones out of the thyroid gland. Then we have the parathyroids. The 4 tiny parathyroids are located on the backside posterior of the thyroid gland. It's going to be in the neck. The thyroid glands consist of tightly packed cells that secretory cells covered by thin capsule of connective tissue. This is just a picture. We have the thyroid gland here and the parathyroid glands here. As you can see, there's 4 of them. And this is on the posterior side or the back side of the thyroid. And if this isn't visually making sense, here's your trachea, which is going to be the front of the neck. The esophagus lies behind the trachea. So that's showing you we're looking from the back to the front of the thyroid. Parathyroid hormone, or PHT, will increase blood calcium ion concentration, and it will decrease phosphate ion concentration. PHT stimulates bone reabsorption by osteoclasts, which releases calcium into the blood. PHT also influences the kidneys to conserve calcium. PHT causes increased absorption of calcium into the intestines, and a negative feedback mechanism involving blood calcium levels regulates the release of PTH. Parathyroid, remember, parathyroid, there's 4 of them, back of the thyroid gland, and they're basically going to be the ones that really look at calcium levels in the body. And they're going to regulate it by a negative feedback system, kind of like a thermostat. And this is basically just kind of showing you, and if we need more calcium in the body, this hormone, I'm going to go back, will stimulate bone reabsorption by the osteoclast, which will release more calcium into the blood from the bone. Calcitonin and PTH exert opposite effects in regulating calcium ions in the blood. So if you have hypoparathyroid, remember the parathyroids are in the back of the thyroid gland. If you have low parathyroidism, then your blood calcium will go down because it's not stimulating, the hormone is not stimulating the bones to release enough calcium. If it's hyperparathyroidism, backside of the thyroid, it's actually causing the bones, the osteoclast in the bones, to release too much calcium into the blood system. So I hope that I'm trying to break it down into something that makes a little sense. Your adrenal glands. Your adrenals are going to sit on top of the kidneys, and they're enclosed in a layer of adipose or fat and connective tissue. The pyramid-shaped glands consist of an inner adrenal medulla and an outer adrenal cortex. The adrenal medulla is made up of modified postganglionic neurons that are connected to the sympathetic nervous system. Remember, sympathetic is what causes things to, most cases, speed up. That would be heart rate, pupillary dilation, things of that nature. So the adrenal medulla in the adrenal glands is going to be affected by the sympathetic nervous system. We talked about that earlier in a lecture. The adrenal cortex makes up most of the adrenal glands and consists of epithelial cells in 3 layers: the outer glomerulosa, middle fasciculata, and the inner reticularis zones. And this is just a breakdown of, and you can see here, this is the adrenal gland, one of them. This would be the left, and this is the kidney that it sits atop. So the adrenal medulla. The adrenal medulla secretes epinephrine and norepinephrine into the bloodstream. The effects of these hormones resemble those of the sympathetic division neurotransmitters of the same name, except for if the epinephrine is coming from the adrenal gland, the adrenaline can last up to 10 times longer in the system when they are actually secreted as hormones. So this kind of goes into, I can give you a shot of adrenaline or epinephrine, it's basically the same thing, and I can raise your heart rate, I can excite your body. But if the adrenal medulla secretes it as a natural epinephrine within the body, that effect is going to last a lot longer than if I would just inject you with like epinephrine. These are used in times of stress and fight or flight responses. Again, when you're scared, angry. Release of medullary hormones is regulated by the nervous impulses from the central nervous system through the sympathetic division and the autonomic nervous system. So again, you get excited, you get mad. Your hypothalamus is going to release nervous impulses from the sympathetic nervous system that's going to go to the adrenal medulla of the adrenal glands, which is going to cause a release of epinephrine, which is going to increase your heart rate, increase your blood pressure, and get you ready to run. And this is just a breakdown from your book of what happens with epinephrine release and norepinephrine release to the heart, the blood vessels, the airways, liver, and also what happens to your metabolic rate. The cells of the adrenal cortex produce over 30 different steroids, some of which are vital to survival, and most of which are aldosterone, cortisol, and the sex hormones. Aldosterone is a mineral corticoid which is secreted by cells of the outer layer. It causes the kidneys to conserve sodium ions and thus water to excrete potassium ions. Aldosterone is secreted in response to decreasing blood volume and blood pressure as a result of changes detected by the kidney. So in other words, if you were losing blood, if your blood volume, your blood pressure was falling, you were going to pass out. This aldosterone would be secreted by the adrenal cortex from the adrenal glands on the kidneys, and it would tell the kidneys to, hey, you better conserve sodium, because if I conserve sodium, I conserve water. And it causes the kidneys to excrete potassium. So what happens? Well, if you are dropping your blood pressure from a trauma or whatever situations making your blood pressure fall, this hormone tells the kidneys to not urinate. It's interesting if we work trauma patients and different things, because the body goes into a survival state, try to conserve and live. And a lot of times we have trauma patients that lose a lot of blood, have low blood pressures, it could be car wrecks, whatever the situation. And when their blood pressure is very low, they will stop urinating. They'll stop peeing if you're working the intensive care unit. And oftentimes we will give that patient fluids. And when their blood pressure gets to a livable level, gets up, we will start to see the kidneys produce urine. And often we'll look at each other and say, oh, the patient's starting to pee again. That's a good sign. That's meaning that the kidneys are no longer trying to conserve sodium. They're actually in a state of, they can go back to normal. And that's because of aldosterone hormone. Cortisol is a glucocorticoid. It's produced by cells on the middle layer of the adrenal cortex. It influences the metabolism of sugar or glucose, protein, fat, in response to conditions that stress the body and require greater supply of energy to the bloodstream. Cortisol inhibits protein synthesis, which increases blood amino acids, and it promotes fatty acid release from the adipose tissue, increasing use of fatty acids for energy and decreased use of glucose. Cortisol has been in the news a lot lately. If you have an abundance of cortisol, this can actually have you hold weight and adipose or fat tissue in the middle gut area. And you'll see that that's in response a lot of times to stress, that the cortisol is released in the body. So I thought I would kind of add that in there because I know cortisol has been a hot topic with weight reduction and fat of the midriff of most people. Cortisol stimulates liver cells to make glucose from non-carbohydrates, increasing blood glucose. So it's going to raise your blood glucose level. A negative feedback mechanism involving CRH from the hypothalamus and ACTH from the anterior pituitary controls release of the cortisol. Stress, injury, or disease can also trigger increased release of cortisol. Again, cortisol, if it's released a lot, can cause you to gain weight, particularly in the midriff or the stomach area. And this is just a depiction of how this all works. And again, it all comes back to the hypothalamus. It's almost like the master controller of the master gland, the pituitary. And that moves us down to adrenal sex hormones. Sex hormones produced in the inner zone of the adrenal glands. So the adrenal glands sitting on top of the kidneys is where the sex hormones are produced. They're mostly in the male type, but can be converted to female hormones in the skin, liver, and fatty or otherwise known as adipose tissues. These hormones supplement those released by the gonads and may stimulate early development of reproductive organs. Disorders of the adrenal hormones, however, are Addison's disease, which would be hyposecretion of the sex hormones, or Cushing's syndrome, which would be hypersecretion. Now, I added a couple pictures in here so you would actually know what Addison's look like and a little bit about it in Cushing. If I'm not mistaken, I believe past President Kennedy had Addison's disease. You might want to Google that, but I remember hearing that somewhere. And which it's going to be hormones from the adrenal system, low secretions. And Addison's here on the left, as you're looking. You'll have darkening of the skin. Usually, this came from Wikipedia, middle-aged females. How do we treat that? Well, if you're hypo-producing steroids, then we give you corticosteroid injections. Hydrocortisones, we can give those to you in pills or injections, and that should, since you're underproducing hormones, steroids, we'll try to meet that for you. Now, just the opposite of Cushing's syndrome, these people will have a moon face. They can tend to have high blood pressure, abdominal obesity, a round red face. They can have acne, and it's prolonged exposure or overproduction of cortisol. Many of these patients you see here on the right also develop Cushing's from taking cortisone. Many COPD patients, asthmatics, anybody that takes cortisone to try to decrease inflammation in the body, which is awesome to do. If you're on it for a very long time, it can actually mimic hyperproduction of cortisone from the adrenal glands and give you Cushing's syndrome. So you may see patients like this, and they either have hyperactive adrenal glands, or you may want to ask them, do you take steroids on a regular basis? And this is just a breakdown from your book of the actions of the hormone and then the factor regulating the secretion of that. And finally, I believe this is the last one. It's going to be the pancreas. The pancreas secretes hormones as an endocrine gland and digestive juices to the digestive tract as an exocrine gland. So it excretes. Pancreas is located in the abdominal cavity, and it's located just posterior to the gallbladder and the bile ducts, and just medial to the midsection to the small intestine. So it can directly influence digestive enzymes into the digestive tract. It's an elongated organ posterior to the stomach. Its endocrine portions are the pancreatic islets, or what we call islets of Langerhans, that include two cell types, the alpha cells that secrete glucagon and the beta cells that secrete insulin. If you don't know a diabetic or have ever heard of diabetes, this is where things come into play, because glucagon helps keep the blood sugar normal, and insulin helps reduce blood sugar when it gets high. A duct joins the pancreas and the duodenum for digestive juices to enter the intestine. And that's just basically a slide, histology slide. The islets of Langerhans, how that is where the hormones would be released from the pancreas. The glucagon from the pancreas, a hormone, increases blood levels of glucose by stimulating the breakdown of glycogen and the conversion of non-carbohydrates into glucose by the liver. The release of glucagon is controlled by a negative feedback system involving low blood sugar levels. So, if your blood sugar goes low, your pancreas should release glucagon. If it doesn't, this is where we get into diabetes and pancreatic issues. I know as a paramedic, if somebody had low blood sugar, we could give sugar via IV into the blood system. We could give, if the patient is awake, we could make them eat sugar, or you can give an injection into a muscle of glucagon that will actually rapidly raise blood sugar levels, which works very quickly if a patient is in need. The other hormone, insulin, decreases the blood levels of glucose by stimulating the liver to form glycogen, promotes facilitation diffusion of glucose into the cells, increases protein synthesis, and stimulates adipose cells to store fat. The release of insulin is controlled by a negative feedback system like the other systems, involving high blood glucose levels. Insulin and glucagon coordinate to maintain relatively stable blood glucose concentrations. Glucagon puts sugar into the body. Insulin takes the sugar away. That's your balance that should occur unless you happen to have diabetes. And this is just a depiction of how this works in your body. But we do have diabetes mellitus. It's a metabolic disease due to the lack of insulin or the inability of the cells to recognize insulin. You have type 1 diabetes, diabetes mellitus, IDDM. It's an autoimmune disorder where beta cells are actually destroyed. You have type 2 diabetes, NIDDM, is when insulin is produced but is not recognized by the cells. And then you have the symptoms, which are hyperglycemia, high blood sugar, glycosuria, polydipsia, polyphagia, and acidosis. Polyphagia is excessive thirst, excessive hunger, and your body can actually go into an acidotic state. We'll talk about that later. But let's go back to type 1 and type 2. Type 2 is there's actually insulin being produced by the pancreas, but the cells are not recognizing it. So you have the insulin, but it's not being utilized because nobody knows it's there in the body. Type 1, you actually have cells being destroyed. And then a few of the other endocrine glands. The pineal gland, remember that's the one I talked about in the brain that we will talk about later. It's a very, very small little gland right in the middle of the brain. It's near the upper portion of the thalamus, and it secretes melatonin. Melatonin you can actually buy over the counter, and it's the drug that actually helps you sleep or relax. It's involved in the regulation of the circadian rhythms of the body. Circadian rhythms are just your sleep patterns. When you're awake, when you're asleep, when you feel sleepy. The fact that most of us go to bed at night, awake in the morning, is all part of the circadian rhythms. It's normally released at night and may help to regulate female reproductive cycles and puberty. Interesting thing about melatonin that gets kind of messed up sometimes is if any of you have to work night shift or midnight shift, it kind of messes that up a little bit because melatonin is released at night. And if you're up all night, can you see how that could throw your body into not knowing if it's supposed to be asleep or awake? The thymus, lying between the lungs under the sternum, secretes thymins that affect production and differentiation of T lymphocytes that are important in immunity. The gland is the largest in children, and it shrinks as we grow older. Then we have the ovaries. They produce estrogen and progesterone. They're located in the abdominal cavity of females. The placenta produces estrogen, progesterone, and gonadotropin, which again from the female system. Then the males, we have testes that produce the testosterone. I want to go back to placenta, which is going to be in uterus, estrogen, progesterone. This is going to, these amounts for the females, I don't have any males in class, basically what's going to regulate the menstrual cycle. Then we have digestive glands. They secrete hormones associated with the process of digestion. And then we have hormone-producing organs. The heart secretes atrial natriuretic peptide affecting sodium and water. And that's interesting. If you go deeper into hearts like we do in respiratory, this actually we look at for heart failure. And then the kidneys secrete erythropoietin for blood cell production. And then I added this, the brain also secretes brain natriuretic peptide, or BMP. And this is secreted if the patient is in heart failure. Often we have patients come to our emergency rooms, or maybe you just know family members that become short of breath. And a lot of people say, well, maybe, there's something wrong with your lungs because you're short of breath. Well, an excess amount of fluid around your heart or in your heart is heart failure. And I'll keep that simple for right now. And BMP should be basically zero in your body. But if you're in heart failure, your brain will excrete BMP, which will it basically is trying to make your body pee or diurese. And the only time it secretes it is if you're in heart failure. So it's a good test. It's a quick test to see if you're in heart failure, if you're having trouble breathing. And then to wrap up is the stress and health. Factors that serve as stressors to the body produce stress and threaten homeostasis or balance. Stressors increase the activity of the sympathetic nervous system, which is going to be your, increased heart rate. And then we have types of stress. Stress may be physical, psychological, or some combination of the two. Physical stress threatens the survival of tissues such as extreme cold, prolonged exercise, or infections. Those are actually physical stressors. Psychological stress, which most of us have, results from real or perceived dangers and includes feelings of anger, depression, fear, and grief. Sometimes even unpleasant stimuli causes stress. And again, these all affect hormones of the body. And let's go back to the cortisol. That's highly related to stress, that you will overproduce cortisol. So in theory, that if you're stressed from psychological stress, you would overproduce cortisol, which would actually make you heavy. Responses to stress are designed to maintain homeostasis. So the hypothalamus controls the stress response, or general adaptation syndrome, which involves the alarm stage and the resistance stage. The alarm stage of the stressor involves fight or flight responses, and what's going to speed up your heart rate. I'll just keep it simple. In the resistant stage, the CRH, which I added this in, the corticotropin releasing hormone, we talked about it earlier, but I wanted to correlate it to CRH, you may have forgotten, from the hypothalamus and the anterior pituitary increase the ACTH, was the adrenocorticotropin, to the adrenal cortex. Actions of cortisol from the adrenal cortex increase blood, amino acids, fatty acid release, glucose formation from non-carbohydrates. So that goes back to what I was saying about the cortisone release from stress. Decrease in lymphocytes, which will lower resistance to infections and some cancers, and long-term risk of high blood pressure, atherosclerosis, and GI ulcers. Let me stress this. This, no pun intended, when we are under stress, whether it be man-made stress or psychological stress, we all have stress from work and families and children and all this. This long-term effect affects the cortisol in your body, and it's going to your lymphocytes fight disease. It's going to lower those, so you're going to be at higher risk for infections. You're going to be sicker more often. You're going to more likely have hypertension. You could have GI ulcers, stomach ulcers. Atherosclerosis is thickening of the vessels around the heart and the body, which could lead to stroke or heart attack. So the importance of not having stress is very important. Other hormones, glucagon and growth hormone, increase to mobilize energy sources. Your antidiuretic hormone, ADH, and kidney retention of water will increase blood volume and pressure, which we kind of talked about that earlier. And this is just showing you a breakdown of how these are regulated and what is actually regulating them. I hope this helped. Please read this chapter and go back through this. Look through all and make sure you're turning in all your homework while I'm away, and doing all the practice questions, because they will help you on the test. I went through and looked at the upcoming tests and tried to give you clues to what to study. We won't have any tests until I come back. So I hope this helped, and I hope you'll have a wonderful day.